Welcome, everybody. We're happy to welcome Zeev Rosberger today for our psychosocial rounds. Zeev is a psychosocial oncology researcher and associate professor at McGill University. His work focuses on the prevention of HPV, with particular attention to psychosocial determinants of screening, testing, and vaccine decision making among young adults and parents. And yeah, Z was until 2017 the chief of the psychology department at the Jewish General Hospital. And I remember meeting him my first practicum with Jewish 1996. Yeah, and I think you just taken over as chief then. Yeah. So he spearheaded the development of the Louise Gronofsky Psychosocial Oncology Program at the Siegel Center of the Jewish General Hospital. He participated on numerous provincial and national committees advocating for improvement of the emotional care for cancer patients and their families. And he also participated in the development of the National Distress Screening Guidelines, which were subsequently endorsed by multiple agencies, including WHO, and implemented internationally. From 2004 to 2006, he was president of the Canadian Association of Psychosocial Oncology, and also sat on the management committee of the Canadian Strategy for Cancer Control. He's currently vice president of HPV Global Action, which is an NGO which provides educational resources about sexual health, and it's developing partnerships nationally and internationally. So we're very happy to have Zeev today talking about his research.
Thank you, David. Thank you both for coming. I appreciate it. Thank actually all of you for coming. And yeah, David and I go back a long way, and to the early days. So I'm going to get right into the topic of the day, and one might ask the question: what is a clinical psychologist, clinical health psychologist doing in cancer prevention and HPV prevention? I recently met with a physician here in the hospital, a well-known physician. I won't name his name, fairly senior. I told him I was going to Bangkok and needed some advice, and going to the International HPV Society meeting to give a talk. And he said, what's a psychologist presenting at an HPV meeting? And I said, well, it's not just about the biomedicine. It's not just about the basic science or the clinical science. It's also about communication. It's about stigma. It's about sexual health. It's about women's health. It's about a whole host of barriers and facilitators of uptake of healthy activities and prevention strategies. And that's where I've landed. So for the last 20 years or so, thereabouts, previously doing more interventions with patients and programs with patients, I've been doing this kind of work, collaborating with graduate students and with HPV Global Action and my colleague, Teresa Norris, who is the president. And I'm going to talk a little bit later towards the end about a project we have just completed in sub-Saharan Africa related to this topic. But I'm just going to go quickly through the objectives. I'm just going to talk because I didn't know who was going to be here and who was going to be online. I decided that I would just give a quick primer on what cervical cancer is about, what the causes are, and so forth, and talk about the critical role of vaccination and screening in the global elimination of cervical cancer. Talk about the factors that facilitate or create barriers to women's engagement in preventive practices, and then talk a little bit about some technological and informational psychosocial interventions that might improve uptake of vaccination and cervical screening in Canada, and talk a little bit about Eswatini and our experience there with an international group in a multi-center trial. HPV is the fourth most, cervical cancer is the fourth most common cancer in women worldwide. And HPV is preventable. Transmission is preventable. Through vaccination, regular screening, we can prevent virtually all cancers. No woman should be dying today from cervical cancer. The highest incidence of mortality are in low and middle income countries, and this is due to limited access to vaccination, screening, treatment, and of course, the recent events in the world where the US has eliminated almost all of its activities and donations, about $8 billion worldwide, including in Eswatini, has placed a great burden on and continuing burden on prevention in these areas. It's caused particularly by persistent HPV infection, and women who have HIV have a 6 times higher risk. So it is the most common STI. WHO has set targets a number of years ago, 90, 70, 90, 90% of young people, adolescents, people being vaccinated, 70% of women being screened, and 90% of women who have active disease being treated. These are very, very ambitious targets. Some places, some countries have done well. We are still lagging behind. I'll talk a little bit about that as well. So there are, as I said, it's the most common STI. There are more than 40 types, and it's sexually transmitted, skin to skin, genital, oral, or anal contact. And all of us, at one point, virtually everyone who's sexually active will come across and be infected unwittingly, unknowingly with, excuse me, somebody wants to. That's not a good sign. Sorry, let me just make sure that this doesn't ring again. Okay. So infections do disappear, or they don't. Others may take a long time to go away. In young women, they clear up on their own because of very good of a strong immune system. Most infections happen during the teen and college age years because of sexual debut, but most people don't know that they've been infected. There are a number of different types. 6 and 11 that cause genital warts, 16 and 18 cause 70% of cervical cancers, 80% of oropharyngeal cancers. Sorry. Anal cancers and so on. So 16 and 18 are the big targets, but there are others, and they can cause serious disease. 99% of all cervical cancers are caused by HPV persistent infections or multiple infections over a lifetime, and they tend to happen in mid to later life, but there's some data to suggest that that's changing. These are the most current statistics that I was able to find, and you can see from this, I think you can see here, yep, where cervical cancer sits. The incidence is very high worldwide, and the mortality is equally high. These are not insignificant numbers, as you can see. Most of them happen in the developing world, and I'll talk about that as well. And you can see that in these maps that show very clearly that most of the cases of mortality are in sub-Saharan Africa, and they parallel the incidence in high-income countries like Canada, the US, and so forth. And in Europe, you tend to have smaller numbers, and in Australia. So that's where the problem really lies. There is good news, however, and I wrote this since I said a backward look. I wanted to sort of start from the end and come back to the beginning, in the sense that while I've been involved in this area, and we've struggled, to get, and the world has struggled to implement programs and practices in countries that have been able to implement structured programs for both vaccine and screening programs in a very sophisticated way, they have made significant progress. So this is an article, a very recent article by Dillner and others, where in Sweden, on a population basis, they've been able to vaccinate close to 85% of all the young women with the HPV vaccine going back now 20 years or so. And they've seen in the population a 99% decline in HPV, high-risk HPV prevalence. What that means is that, and this is also true in those who have not been vaccinated. So in fact, what they're discovering is that herd immunity is taking over. And this has been, so this is current. So if you have a program, if you have coverage, you have efficacy and the circulating HPV. It's a bit like MMR vaccine and all the kids who got it, and 95% coverage means that kids don't get the measles. And in South Carolina right now, there are big outbreaks of measles. What's happening right now over the last number of years is actually, in spite of our attempts, having programs. Where is it? Okay. You can see that here in younger cohorts of women, that in fact, more recently, incidence is going up, whereas in older cohorts of women in the 50s, 60s, and 70s, it continues to go down. This is very concerning, and it mirrors actually increases in colon cancer and other cancers in younger people. And we're not quite sure why that is. Part of it could be because we haven't reached the rates that we wanted to. So our research program over the number of years, and I wasn't quite sure how to present what we've been doing, but I thought I'd do a hop, skip, and jump over the last 10, 15 years, give you some highlights of some of the research we've done, some of the implications, and some of the impact that we hope we've had in the community and on policy and implementation of intervention strategies. So we started off by looking at vaccine decision-making when the vaccine first became public in free school-based programs. There were catch-up programs for college-age males and females who tended to have a high prevalence of infection. So we did surveys with them. We developed, there were no measures, and you can't know what's going on unless you have valid measures. I never thought I'd become a psychometrist, a psychometrician, but we developed quite a number of valid scales that I'll tell you about as well, that covered knowledge, attitudes, beliefs, and we looked at hesitancy, and which is now a dirty word in America. The NIH is not allowed to use the word vaccine hesitancy. I believe that was mandated. All the studies that were working on vaccine hesitancy have been stopped. And we're also interested in screening and testing and the changes from Pap testing, which has been the tradition, Pap smears and colposcopy, which is still being used, and self-sampling. And I'll tell you a little bit about self-sampling and looking at that. There were 3 different vaccines used for primary prevention over the years. Right now, it's Gardasil 9. That's the main vaccine that's used worldwide. There are others, so covering not only 16 and 18, which are the primary movers, but there are others in different regions, other types of HPV that are oncogenic that it covers. And there are, I believe, in process development of vaccines that cover other types, high-risk types as well. But they cover most types. They're highly efficacious. Sorry, I'm going the wrong way. Highly efficacious. And countries have developed programs. I said in Canada, there was an implementation first with girls. I'll talk about that in schools. DNA testing, moving from traditional Pap smears, the technology is there. It's a much more highly sensitive test. Self-sampling can be used, and the samples collected by women using self-sampling swab that you see in the picture. The concordance between self-sampling and healthcare professional self-sampling is virtually 1. It's in the high 90s. So it's a very effective, and even though women sometimes are afraid, they in fact have anxiety about whether they're collecting it properly, it's actually quite effective. We're still lagging behind, as I told you, in Sweden and other European countries, the Nordic countries in particular, but even the UK and Australia have implemented screening programs, very effective screening programs, not perfect, but we're still far behind. One of the problems is that we have 13 different health jurisdictions, and each province and each territory is developing their own process. So we started off by looking at decision making and tried some interventions. You can see from some of the studies we did early on with my first graduate student in this area, Andrea Krawczyk. We looked at college women. We looked at an early study in Quebec of parents making decisions. And we also looked at and worked with colleagues to look at the myths, misinformation, the stuff online that was coming out, just as you see right now about COVID vaccine, we were seeing with the HPV vaccine in its early days. So this paper actually is still quoted, quite highly. We then embarked on some larger scale studies of parents of girls and then parents of girls and boys, 2 major surveys that were led by 2 of my brilliant graduate students, Gila Shapiro and Samara Perez. Some of you may know they were both around here in the 10 years ago. And we were surveying parents, their attitudes, their knowledge, and so forth about their decision-making process for their children in an attempt to understand what the barriers and facilitators were. One of the papers that Sam took the lead on, it was a qualitative piece. I didn't even know boys could get the vaccine. So there was a lot of misinformation, lack of information, and misunderstanding about why would a boy need to get a vaccine to prevent cervical cancer. Well, it's the boys that are transmitting the HPV virus back and forth, and men do can test positive for the HPV vaccine. We became interested in this whole issue of male, female. There was a lot of controversy. There were a number of studies looking at models of giving only girls, what level you'd have to get in the community, and then including boys and not including boys. It turned out that the study suggested, in fact, that if girls were vaccinated up to about 80 to 85% in the community, that this thing has a life of its own, that in fact, we wouldn't have to vaccinate boys. We could save a lot of money. We in our group with Gila and Sam and us, we had many discussions about this. And we took the position that a gender-neutral approach would make more sense. And it came to light when we saw that in British Columbia, the chief health officer decided that they would vaccinate high-risk boys only. And what they decided were high-risk boys were young boys, 15 to 18, who were gay, and street youth, drug users, and so on, because transmission and drug use. And we sort of thought, well, what do? You go into a classroom, you say, okay, all the 15-year-old gay boys, raise your hand, we're going to give you the vaccine. it really didn't make sense to us. So we took it upon ourselves to write some opinion pieces that were actually published, and we got responses from Perry Kendall, and we went back and forth. I'd like to think that we had some influence. I think we did have some influence in moving to a gender neutral across the country. I don't think it was the only thing. I think part of it was that vaccination rates for girls were not getting up to 80-85%, which was necessary for herd immunity, and therefore that became an issue. Gila did a policy analysis, which is part of her expertise, because we were interested in why some provinces included boys and not others. But what she found was that through some of our own studies, that when the government doesn't fund, not only cost, but perception of the vaccine has changed. If the government doesn't think it's important, why do it? In Quebec, there is a ethos amongst the population that if the government says it's a good idea, they'll do it. So Quebec has actually been done very well with the vaccine uptake, particularly the HPV vaccine. So we've taken some positions, we've been involved, and I think it behooves us. And that's one of the things that I felt we should do, is not only do the research qua research to publish, to share with our colleagues, to do KT, as it were, but also to get involved in the trenches with policymakers and give our opinions to the public and so forth. So I think we might have had some. So in our research, we also realized going forward that in order to understand vaccine hesitancy and vaccine uptake, that we needed to find a model that was beyond just asking, has your child received yes or no? If you'd ever heard of it, you don't know what to answer. They might have gotten it at school. They don't know. They never thought about it. They're undecided. Yes, they might know about it. They're against it. What we did was we looked for a theoretical framework that would help us understand better what the process was about. So we found this model. It's a stages of change model, and we liked it better than the trans theoretical model. And we asked people, parents, where they were. Were you aware? We give them a little blurb about the vaccine in the questionnaire, the survey. And we'd ask them, were you aware? No, I was aware, but I wasn't involved, not engaged. I knew about it, but I was undecided. I decided, I got my kid vaccinated, or I decided not to vaccinate. And we use those categories to look at correlates of vaccine hesitancy in parents of girls and boys. And I'm going to show you a little bit about the boys because I want to keep it simple. So the results are really interesting. Parents and boys and girls were categorized as flexible, hesitant, if they were unengaged or undecided. And we looked at them at 2 time points. We surveyed them online at time 1, and then 6 to 9 months later, we surveyed the same group and to see where they were and asked them to complete the same precaution adoption, their status in the PAPM. Those that were unengaged, undecided changed over time without any intervention. It's just natural, whatever was going on over time. There was no intervention. We changed their attitudes, behaviors, knowledge, and intentions to vaccinate compared to rigid hesitant, those who were decided not at time 1, who remain largely unchanged. Flexible hesitant, greater social influence to vaccinate from family, from a healthcare provider, due to social norms, increased HPV knowledge, higher income, white ethnicity, and lower perceptions of harms were associated with higher vaccine acceptability. So this is sort of another way of looking at this. If you look at, these are for parents of boys from time 1 to time 2, looking at it this way. At time 1, those who were undecided and unengaged over time moved more towards deciding to vaccinate, and actually some got vaccinated. This is of these 323 that we were able to retain from time 1 to time 2. Although many stayed undecided, A few decided not to vaccinate, but really there was a tendency over time to go forward. When you look at parents who were decided not at time one, parents of boys who decided not to vaccinate, what we called rigid hesitant, what we saw was of those 9%, most of them decided not. They were really rigid. None decided to, but actually 1% had their child vaccinated. So it was very interesting to see that vaccine hesitancy changes over time. It depends on who's talking to whom, what information parents have, what access they have, whether it's paid for or not, etc. It was very expensive. The initial cost of the vaccine was there were 3 doses initially, and it cost $150 a dose. It was not cheap if you had to pay for it. So as I said, flexible hesitancy changes allows people to those who are flexible allows for changes over time and are associated with higher vaccine acceptability due to social influence, increased knowledge, etc. And the rigid hesitant remained mostly unchanged. We also looked at this from the same sample, where the children were. There were, at that point in time, some provinces had vaccination for boys, some did not. And we looked at differences between what was of correlates of uptake in provinces that were just coming on, those that had still not brought on boys, and those who had had boys programs. And what we found was that jurisdictions with funding for boys at both time points, because it was time one, time two, had higher odds of vaccination than jurisdictions without funding at both time points. However, funded jurisdictions did not have higher odds of vaccination compared to jurisdictions that newly introduced funding for boys. Vaccination was associated with consistent determinants in boys and girls, including age, healthcare provider recommendation, perceived affordability. So if you institute a program, as soon as you institute a program, people get on board. When there's cost and the government's not supporting it by perception, then there's more hesitancy and less likely to have uptake. As you can see, this is a little bit old now, about 5, 6, 7 years old. But if you look at the different provinces, there seem, in terms of uptake of boys and girls, you can see that in the east, there tends to be higher rates. And as you go west, the rates tend to drop. It's very interesting. We haven't quite figured that out. And more recently, this is more recent data, when you look at the 90% target rate by the Canadian Partnership Against Cancer and the National Advisory Committee on Immunization, according to the WHO guidelines, you can see that some provinces, Quebec has done reasonably well, Prince Edward Island, but Alberta, British Columbia, Manitoba, the East still doing better, but not reaching the target set. Now, just yesterday, there was some new data, just yesterday, as I was putting final touches on this talk, there was an announcement from the Canadian Partnership about new modeling that suggests that maybe, and I think if I understood it, I read it quickly, that maybe the 90% target for vaccination was maybe too high, but that targets might be reached by 2040, even with a 70 or 80% target rate, depending on the screening. So I can't give you more details because I wasn't able to get into the details of the announcement. So things are changing even as we speak. I talked about developing scales and psychometrics. A lot of data that was presented was very anecdotal, qualitative. We decided from our data to develop a number of scales that have, some of whom have gotten fairly wide use. The vaccine hesitancy scale is one of my highest cited papers from our lab. still gets cited, been translated to many languages and still gets used. We developed a scale of HPV attitudes and beliefs, knowledge, and a vaccine conspiracy beliefs scale. These have been used widely. We've used them in some of our studies, but I think that these are tools that people can use. They've been adapted. They've been now changed and modified in various different ways. As I said, the context is important. It's not just about individual decision making. It's also about the cultural and political context. Japan went through, there was a sharp decline in uptake when the Ministry of Health suspended recommendations in June of 2013 because of activism from parents who said that the vaccine was dangerous and so forth. There are no known significant side effects from the HPV vaccine, but some of the things you would see on YouTube were amazing. And there was one video of a girl that could only walk backwards like a duck, and it was because of the vaccine. Those are the kinds of things that we see. These are the kinds of reports that we get all the time, these anecdotal reports. Correlation does not mean causality, as we all know, particularly with a single case. Since then, in recent years, this has changed, and the vaccine programs have been reintroduced, and things are going much better in Japan. We've had our own issues in Canada. The Bishop of Alberta, Bishop Henry, decided that the HPV vaccine should be banned in the Catholic school systems in Alberta and then in Ontario because it was a sex vaccine, that somehow that young girls who received the vaccine would take that to mean, oh, I can have sex. I won't be transmitting the HPV vaccine, so I can have sex, not a problem. This was kind of very misguided. My colleague, Juliette Guichon at the University of Calgary, who's a strong advocate, and I and others pushed back considerably. But the data suggested in two reviews that we participated in, the one on the left about risk compensation research and the one on the right. And it turns out that the more information you gave parents, the less likely they were engaged, that kids were likely to engage in sexual activity, promiscuous sexual activity. The more information, and if you got them vaccinated. After vaccine, with the vaccine, you get some information, you get some, it prevents HPV transmission, but you can still get syphilis, gonorrhea, chlamydia, all kinds of other infections. And so they would get some teaching. So surveys in the South and Southern United States, girls who got this information and got the vaccine tended to have less pregnancies than those girls who didn't get the vaccine. Interesting information, but based on data. Gila put together this multivariate vaccine hesitancy model. It's not the current one, but I just wanted to show you how complex this decision-making process can be. All of the influences from the contextual, the physical environment, parents' views, health professionals' recommendation, which by and large comes out in almost every study as the most important factor in many studies of vaccine decision making. The opinion of others as well, family members, etc. Whether there's a program, whether it's covered by the government, and so on and so on. So you can see all of these factors that influence vaccine attitudes, and I've touched on some of them already. So let's talk about screening. And why it's important to understand what influences women to accept HPV testing. It was when the HPV virus was discovered to be the main cause of cervical cancer, there was a push to see if tests could be developed to screen for HPV, as opposed to looking at cells, abnormal cells taken from a scraping from the cervix under a microscope, the traditional pap smear, which was very effective in its time. And it turned out that, in fact, in a major study done by a colleague of mine, Dr. Franco, here at McGill, who was a major influence actually for me to get involved in this area of research, doing a randomized trial of PAP versus HPV testing in 10,000 women in Quebec and in Newfoundland. And they published a seminal article in 2007 in New England Journal of Medicine showing that the HPV test was much more sensitive and much more less specific when compared to pap smears. In fact, the specificity was in the 90% range in terms of picking up a real high-risk HPV through the DNA testing, whereas the pap smear was only about 50% sensitive. So, as Dr. Franco has said in many talks I've heard him give, the pap test was more a flip of a coin than being accurate in predicting the possibility of having advanced disease. So what we did, and I'm jumping ahead a little bit, we did a first, as what was the first step before you dive into actually talking to people, is we looked at the literature and we did a systematic review of test acceptability in primary screening for cervical cancer. And we used qualitative approach. And I'm just showing you this. I'm not going to go through it in any detail because it's complicated, but it gives you an idea of using factors through. We synthesize the themes from the systematic review through the lens of the health belief model and the theory of planned behavior about acceptability. So we came up with a lot of possible facilitators, as you can see, possible barriers, marital status, if you're single, negative attitudes toward delayed part of screening, screening if you have an HPV test and it's negative, then you don't have to come back for 5 years, as opposed to women who are used to going anywhere from 1 to 3 years intervals for pap screening, et cetera, et cetera. Some contradictory evidence and no impact. So we looked at this and took the evidence from the systematic review, and with the recommendations from the WHO that DNA testing finally should be a first choice screening method for cancer prevention, based on the data that I described and the results of many studies showing the higher sensitivity of picking up disease than of a DNA testing picking up disease than the cervical pap smears. And if you looked at incidence of cervical cancer by the Human Development Index or by level of development of different areas of the world, it becomes very clear that the burden of cancer and disease worldwide is in very low on the human development, on the HDI, countries with very low. These are where you get cases per 100,000 in the 80s and 90s, and so forth. And I'll talk about Eswatini in a bit, and the work that we started there, where the cases per 100,000 was in the 50s and 60s, as opposed to here in Canada, where it's 12, and we're hoping to get down to 4, which is the level that the WHO is suggesting would be considered elimination of disease. So testing has been introduced in Canada. BC is way ahead, but because we have 10 different healthcare systems. Australia implemented a program without informing women. There was a backlash an online petition saying, what the heck is this? You haven't told us anything. You're telling us we should go get tested with HPV DNA, HPV testing, not with PAP, and then come back in 5 years. What does that mean? What happens? You haven't answered our questions. We thought that this could happen here as well if there wasn't timely introduction of cervical screening. And so, and we have issues of underscreening, women who never or rarely get screened. And we thought that it would be important to understand attitudes and preferences of Canadian women towards these changes. What about Canada? The Netherlands, they were talking about a 10-year screening interval, and that really scared women. I don't think they've gone to 10 years, but they had considered it in their national program. So we got a grant. We were unfortunately interrupted by, got it in 2019, we were interrupted by COVID, which changed screening practices. Of course, women were not getting screened. So we delayed the implementation of this particular survey and looked at, and I'll tell you a little bit about that. The age of initiation was changed from 20 to 25 or 30. The screening interval was changed from 5 to 10 years in terms of recommendations, as opposed to 2 to 3 years for PAP. And the introduction of self-sampling, which is a major, major technical innovation in DNA and HPV DNA testing, which meant you didn't have to go to see a healthcare professional. You didn't have to go see your physician, get up in the stirrups, unless you had other reasons to go. And you could get tested, maybe do home self-sampling. And this is one of the things that we've been pursuing. And have easier access to marginalized and underscreened populations. So those women who were unconnected, so many people do not have access, do not have a GP, don't know where to go, don't get information. There is no structured program in Quebec like we have in for mammography, where women over 50, I believe, or maybe 45 now, are getting letters to come and have a mammogram and to make an appointment. We don't have that program in place yet. We've been fighting for it for a long time. But underscreened women particularly have a higher risk, and underscreened women tend to be new immigrants, people who don't speak English or French, people of low socioeconomic status, etc. So this is the paper that I was talking about of Dr. Franco, which shouldn't be here. We also did a systematic review with Emily McBride, who was a postdoctoral fellow from UK who came and spent a month with us. And we piggybacked this systematic review on top of Dr. Tatar's, the previous one that I showed you. And what we found, we were looking at emotional responses to positive or negative tests. So this is more clinical in nature. And what we found through the review is that women who tested positive for HPV and who had abnormal or even normal cytology displayed in a triage, displayed higher short-term anxiety than those with normal results. And there were no long-term differences between the two. Distress, general, sexual, test-specific was higher in positive women, obviously with abnormal cytology in the short term and the long term. And testing HPV positive was also related to disgust and shame, surprise, and fear about cancer, even though most precancers can be treated through previously cryotherapy, thermal ablation, and some minor surgical procedures like LEAP, and can be cures before they become invasive cancers. So we had some sense of why it would be important to understand women's. I had told you previously that women considered self-sampling in many, many studies highly acceptable, but were willing to do it if they did it once, to do it again. Because of the ease of use, privacy, you do it in the bathroom, comfort, convenience. Those who didn't like it felt that they didn't have confidence in how to do it, and collect it, make sure they got the right specimen. Some women have a discomfort with, obviously, with the procedure itself, and created some anxiety. But underscreened women, obviously, very critical. So we did this survey. I don't remember now. Yeah, we only published it in 2024, but we actually got the grant in 2019. A national survey of about 4,000 women across the country, women underscreened and adequately screened. Adequately screened had either an HPV test or a pap test in the past year. Underscreened had not. And we did this web-based survey, and we had a look at so we measured all kinds of things. We developed new scales of cervical cancer knowledge, HPV testing knowledge, HPV general knowledge scales. And the outcomes were intentions for receiving the test, intentions for self-sampling. And again, we used the same precaution adoption process model to assess change or intentions. These are the data. So for and I'm not going to go through it in any detail, but just to show you that we measured all of these factors and then through this forest plot looked at which of the factors showed relationship with intentions. So these are adequately screened women, HPV test intentions, comparing tested versus unengaged, already tested or unengaged. And you can see that being in an other ethnicity, lower income, and having worries were related to test intentions. And in the underscreened, we saw, again, Indigenous versus North American having higher challenges, other ethnicities. Being in Canada less than 10 years, and we took this particular factor into our most recent proposal as being important factors in determining whether someone had intentions to get tested. Subsequently, we looked at self-sampling intentions, and we saw that a sense of personal autonomy meant you were more likely to use it, having more confidence, and having a history of an STI. In adequately screened women and in underscreened women, similar factors. There were really no difference. Having a sense of personal autonomy, being in Canada less than 10 years, and having a history, more likely to intend to use self-sampling. So the conclusions that increased knowledge can increase HPV test-based screening intentions, improving test knowledge can increase HPV test-based screening intentions, low knowledge and interpretation of the HPV test results, possibility of self-sampling as well. Addressing personal barriers, increasing confidence can increase intentions, need to correct worries, in other words, provide reassurance about the increasing age of screening debut from 18, 19, 20 to 25. As I said, there's no necessity really to screen before 25 because almost all infections clear up on their own, and testing really is unnecessary. Longer screening intervals, obviously, going up to 5 years and maybe to 10 years. Women were concerned about that. Concerns about self-collecting. We talked about that, about not doing it properly or injuring oneself, and looking at higher autonomy. Oops, wrong one. So, targeted communications to address these, interactive communications, implementation of self-sampling as part of organized programs to reach women, tailored interventions for older groups because of lower screening intentions, and opportunities in underscreened. They showed higher intentions if they came from these areas. So we took this data, I'm just going through this very quickly, and we've put together a proposal to develop a web-based tool. We've now, unfortunately, had several rejections from CIHR, and we're going to submit it next week to the Canadian Cancer Society, where I think it fits better. We're hoping to develop the tool and do a pilot RCT with underscreened adults here in the Montreal area, leaving it in the local community and working with the community partnerships with HPV Global Action, with the Coalition Québécoise de Cancer to help us work with community groups where women who of low SES and new immigrants who are the higher risk groups to have access to them and then randomize them to two groups, one receiving the web-based tool and the other just getting an invitation to participate at home. So it's about self-sampling primarily, home-based test sampling. And we're hoping that this will be the next step. We developed the model from the data that you've seen from this intervention, from the survey, and using the COM-B as a development tool, really using theory to guide the proposal. And I'm not going to get into more of that in detail, but that hopefully will be our next step, one of our next steps. So a lot of these things have not gone on sequentially, they've gone on in parallel, and I want to share with you in the last 10 minutes or so what we've done. And I think this has been a very exciting journey over the last several years, where we were given the opportunity to work with partners in Norway, Dr. Aaron Ketland, who's a world authority on female genital schistosomiasis. I'll tell you a little bit about that. And Kolasili Dlamini, who is in Eswatini, who is I think she still is the director of the Cancer Control Program, and other partners under the rubric, a partnership with HPV Global Action, the National Cancer Institute in the US, to develop this project as part of a multi-site project to look at point-of-care HPV testing using self-sampling in hard-to-reach areas of the world. So that we were one of 9 countries that were involved in what's called the PAVE project. The PAVE project is about automated visual evaluation. So we worked here in southern parts of Africa. Eswatini is a very small country with the highest levels of HIV and HPV in the world. We focused on women aged 20 to 49 using this cutting-edge PAVE technology. I don't have a picture of it, a new picture of it. It's a handheld colposcope that takes pictures, that's connected to the internet. Doesn't have to be, but is connected to the internet, and can also has a mechanism where you can attach a probe that can actually do thermal ablations as well. The idea here is that the goal was to take pictures of the cervix before and after using acetic acid, which is the traditional way of identifying lesions on the cervix. Over 50,000 pictures were taken through the different countries, sent to the NCI under the leadership of Mark Schiffman, Dr. Schiffman at the National Cancer Institute, who's one of the world leaders in this area. And through using deep learning and AI technology to develop algorithms between the visual identification of the lesion and integrating it with the HPV result. So we engaged, we were lucky, we were given the technology, and we decided to work in this country. And as I said, the age standardized rate is 59.2 per 100,000. In Canada, it's about 12. And the prevalence of HIV is 25%. So we're dealing with a very a country with high endemic rates of HIV and HPV. And there is a comorbidity between HIV and HPV as well. Now, female genital schistosomiasis, we're partnering with Dr. Ketland, is a waterborne parasite because women who live near these streams they swim, they wash, they use the water for cooking. These are parasites that go through the skin, live in the body, deposit eggs in different organ systems and in the cervix and the vaginal area, and often look like cervical cancer precancers or cervical cancer lesions. So the idea was to address both of these and see if we could differentiate for both diseases using AVE and to determine the influence of FGS on cervical cancer development. So we're at that stage where some of that is being done, where we've collected the data, but it has not been done. Also to see if this algorithm that was developed through these AI and deep learning could be scalable to different countries in similar settings. My role here, specifically, although I was involved in development of the entire project with my partners at HPV Global Action, Dr. Stebbin and Teresa Norris, was to assess via interview surveys and focus groups the feasibility, acceptability of participants and healthcare professionals in this area, because we're bringing a technology to a very remote area of the world. And just to show you, we do have a graduate student on the left, and I promised I'd show her picture. I demanded that I show her picture. Alice Tembe is interestingly, I did not know anything. She's very humble, but she's actually a very accomplished women's health advocate in Africa. As you can see, she's on the cover of this magazine last year. And she's been working with us for the last 3 years, collecting data and being supervised by Thrusha Naidu, who's from South Africa, but who is now Canada Research Chair in Equity and Social Justice at the University of Ottawa. And we've been meeting weekly. We're at the point now where Alice is analyzing her data. It's going to become her doctoral dissertation, looking at the data from the perspective of African women, learning a lot. I've been learning a lot about decolonial approaches and theories related to understanding the African experience and the African woman's experience. And this is going to be some very interesting data that we will present. This is the group. Here I am. I was actually there once. We worked with the community there. This is Teresa. This is Dr. Ketlin. And I need to show you where this clinic is. This is the Bella Rural Health Center where we collected data. And it's actually at the end of this 28-kilometer, it's hardly a road, but it is a road, often washed out, and you can see the potholes are bigger even than in Montreal. It's quite an experience to be there. So this is a fairly remote clinic where we incentivized women to come by offering them bus fare, because women had to come from the villages in the local community. They had children. They needed to leave their children. Often they had to be back in time. Buses don't come that often. We subsidized with a sandwich and bus fare so that women could come for their screening. Whoops. Let's go forward. Okay. So this was the algorithm. Basically, women would come to the clinic. They would check in if they had HIV with the HIV clinic there, be registered. They would come to the integration building. They would check in. They would sign consents. They would review and so forth. They would wait. The nurse would provide the self-sample swab, a urine container that was collected as well. And we had in the bathroom pictograms of how to collect the sample. The nurse would collect the sample from the toilet stall. The nurse would go over, would do a 20 to 30 minute gynae exam. So they were actually seen and the pictures were taken. They were provided with bus fare home. And we had a lab on site with a portable PCR machine. So the DNA testing was done on site. Any lesions that were visible after acetic acid were treated by the nurse. The nurse was trained to treat and do ablations. And then the women, after the DNA samples were analyzed, women were called back for follow-up. So we had 702 women, I found out the other day. In fact, 286 women tested positive for HIV, a 46% positivity rate. It's a convenient sample. One might think that there were women who had concerns about their gynecological status, maybe had bleeding, maybe had other issues. So it could be a slight overestimate, but still very high and consistent with the rates that we've seen in the country. And 119 women are being followed. We're still trying to reach some of the women at the time that this presentation was made, that Teresa made this presentation. 200 of these women were HIV positive, representing a significant subgroup potentially at higher risk. And among those women, among the 286 HPV positive women, 37% of those were also HIV positive, showing that comorbidity. And 21 women, although we weren't sure of that, 21 women also had all three. So this is a recent publication in JNCI of this algorithm. I don't know how well you can see it, but at this point, these preliminary data. Now, this algorithm was not used for diagnosis. We were collecting data. This was not an efficacy trial. This was just looking at collecting this data. And this algorithm was developed for HPV 16 and two other, come on, where is it? And other groups that were tested. There were what's called extended genotyping, 16 by itself, 18 in another, and then two other groups that were tested with the machine. And this was, I don't know how to use these. And then the results showed whether this was low, medium, or high risk that required referral or follow-up. This hopefully will be tested in an efficacy trial, what we call PAVE 2.0. Unfortunately, the plans for that were put on hold because of what's gone on in the States, but that was the original plan, is to go forward with the second wave, but we might still be able to follow up with another trial. One of the things that we've learned in this post-colonial era is that many of us who come from the West, high-income countries, to do research, go to these places, just like with our own indigenous populations, collect data and leave, and don't leave anything behind. That was not the goal. We did an implementation. We took an implementation approach to this. The sustainability issue was part of that. And as it turns out, we just found out, and I don't know if it's actually a hard fact yet, that in fact the country is going to take up this particular approach of screen and treat, one-stop shopping, and disseminate that hopefully throughout the country. We hope that then this algorithm can be used with the handheld colposcope to actually ensure the diagnosis and make sure the treatment is the right treatment. So this will be part of an ongoing trial, possibly in Eswatini. I don't know if that's going to happen with us, but we can take those learnings, not just from Eswatini, but from the other countries around the world, from Cambodia, Tanzania, other countries, Central America, middle, and low income countries, and bring that learning here. We have pockets of underscreened, hard to reach populations, indigenous groups, et cetera, and where clinics are not available or women are afraid to go to clinics or resistant, these approaches can be done in the ground and on the ground in pop-up clinics, perhaps. And we're looking at partnering with local indigenous groups. It's not set in stone yet, but the negotiations are ongoing, where we might be able to use the same technology locally that we've learned with our partners elsewhere. So, how do I get out of this? Okay. Alex, how do I get out of this Okay, got it. Okay,
Do you want?
got it. I'm good. I'm good.
Good?
Yeah, I'm good. Sorry, I figured it out. Teresa Norris here, you said it presented this data, this information. We're planning to write a paper about. One of the big challenges is actually working with the community. It took us a long time to develop relationships with the community so that we didn't appear to be these colonialists coming in, grabbing, taking, and how to sensitize the population, to mobilize the population, to work with local volunteer healthcare workers, to make sure that we would be successful. And Teresa has come up with this sensitization, mobilization, recruitment strategy that seems to work very well and really helped us get through this. So these are the same. So I've come to the end of my talk. Our next steps are to try to get this grant that I told you about, possibly work with local Indigenous communities in our neighborhood to do some implementation work with other colleagues. There's other work that we're doing as well, evaluating other projects. I knew I wouldn't have much time. There was much more work that's gone into this. This is just a small number of the collaborators. We've had multiple grants from CIHR and a little bit of money from the Quebec government early on. There are some people who aren't here, my colleagues from HPV Global Action who've been absolutely incredible partners that I've worked with. In fact, we're having our annual dinner tonight, and I'm looking forward to it. And my students, all of the students, research assistants, Dr. Tatar, Ovi Tatar, who's been my right arm, literally, brilliant, a man who has made such major contributions to this work, and without whom I would not have gotten this far. He continues to work part-time with me in supporting our work. And our graduate students, Gila Shapiro and Samara Perez, who are both very accomplished researchers in their own right at this point, still collaborate a little bit with them as well. We've done some work with COVID. Over the COVID, we were sustained by 4 small COVID grants, and we're still just finishing one up right now, qualitative piece. And while I am who I am and where I am, and I've been here a long time, I'm not ready to hang up my skates just yet. So thank you very much for inviting me. I hope that this has been instructive and interesting. I've done my best. And you two get a prize. I want your names because I want to give you a prize, okay? For hanging in here. Thank you. Are there 20 people? Well, they didn't show up, so they don't get a prize. They get a prize for sitting here in the cold.
Yeah. Thank you very much, Steve. That was a wonderful talk. And okay, so far don't have any questions.
No questions.
But
I answered everybody. Oh, there's Jaswan. Hi, Jaswan. Long time no see.
Yeah, I'm in Victoria, but thank you very much. It was a wonderful talk.
I appreciate it, Jaswan. Thank you.
I just want to, I mean, with what's going on south of the border, and I don't know how that, if you could elaborate on that. And also, is there any connection with, because we notice Alberta, like the Western provinces, so similar attitudes towards vaccinations.
Yeah.
Do you notice?
Yeah, no, it's a fact. Alberta has pulled back on vaccine mandates. In fact, I think there are no vaccine mandates anymore in Alberta. I can't say for sure, but they really are extremely conservative and taking on much more of the attitudes that we see in the US these days. There was a report, I think, this morning that the number of measles cases in North Carolina in the last 10 days have gone up to 300 and something, and only 2% of those were fully vaccinated. There's a reason why vaccines work, because they work. They're not perfect. No vaccine is perfect, but not getting vaccinated, I think, it's a bit like, it's one of the greatest public health innovations that we've had in our lifetime. And that, and in the late 1800s, sewers. Did you know that development of sewers was one of the biggest public health? Because when sewers were open outside and people didn't know that you get cholera and disease and so forth, when they started putting them underground and you had clean water, people didn't get as sick. I mean, these are amazing stories of public health. Now, I never thought when I started out, I was a clinician. I started here many years ago. I got interested in health issues and cancer and so on, and had most of my career in that area. Never thought I'd become involved in public health and community, working with community organizations. Have work with policymakers. I was involved in some CPAC meetings, Canadian Partnership Against Cancer. What you mentioned, you said I was on the management committee. When you introduced me to the management committee of the Canadian, I forget what it was, Strategy Against Cancer. That was an amalgamation of public and professional and NGOs all advocating for the government to get involved in cancer control. And we developed that, and we actually stimulated the government to implement what became the Canadian Partnership Against Cancer Control, to develop national strategies. So I never thought I'd be doing those things. And now that I think about it, I guess it's history. But and so I continue with this effort. The thing that drives me is the thing I said at the very beginning. If a woman gets vaccinated and a woman gets screened regularly, there's absolutely no reason why she should die from cervical cancer. There should be close to zero deaths from cervical cancer. It's the one cancer that we have absolute evidence that we can make this kind of impact.
Great.
There was a question online, and then maybe we can ask them.
Sure. So from Christoph, you said no need for screening before 25. Is there any specific group that needs to be screened before 25?
I think that probably anyone who's immunocompromised, possibly as a possibility. Off the top of my head, I can't think of anyone. There was this, if the relationship between HPV infection and persistent infection is also multiple partners. If you have a history of multiple partners, that's a risk factor. Smoking actually is a risk factor as well for development of cervical cancer, because it affects the epithelium in the cervix and it does something to facilitate proliferation of the cancers. I had a patient. I was going to show at the beginning from the clinical side. I had a patient when I was still doing clinical work here. A woman, 60. She just graduated. She just retired as an art teacher. Very beloved. They made a wonderful retirement for. And she developed cervical cancer, invasive cervical cancer. And I followed her until she died. I never brought up at the time. I never brought up the issue of HPV. But she said to me one day, she said, "Did I have HPV?" And I said, "Yeah, probably that's the cause." She said, "Well, where did I get it?" "It's sexually transmitted." She said, "But I only had one partner." Her ex-husband, who had multiple partnerships during their marriage, as she discovered later, which is why they got divorced. One might hypothesize that somehow he transmitted, this to her. And it's rather tragic. Lovely woman.
Yeah.
Okay. So can I ask?
Sure. There's one other question, but I will go to Ashley.
I know
Yeah.
that this sort of dovetailed into some of the COVID vaccination, the occupation and all that. Do you want to, maybe now we have a few years of perspective, and I'm just wondering whether that has been it has helped the enthusiasm around the uses of vaccination, or you still feel like there's a lag that you're catching up from all of the media, there's a very conflicting media media around vaccination.
Well,
just wondering if you talk about that.
We did we developed two interventions for young adults. We had two small studies, and we did two follow-up qualitative. We just finished actually collecting qualitative data around that intervention. So I've been listening to I did some of the focus groups myself, and listening to young people meaning 18 to 39, who tended not to get vaccinated in the early stages because they thought they were healthy and so forth. And then did, as the pandemic um, continued, they did start to get vaccinated. It depends on their attitudes. We use the same precaution adoption uh, model to ask them before they came into the focus groups where they were now. Were they anti-vaccine? Were they not going to get it? Were they undecided, or had they been vaccinated? You get very different kinds of. We haven't analyzed the data of all the groups yet, but we did it across the country. We did 12 groups across the country, and it's interesting because some of them say, well, it's not the ones who took the vaccine say, well, I'm not anti-vaccine, and like the flu, I think I should get it, protect my grandparents. I don't have a problem with it. The others feel, the ones who were anti and never got the vaccine, or were, because they saw somebody get very sick after they got the vaccine, or they got very sick after getting the vaccine. There's still issues around, well, the pharma's just out to make money. Those are still predominant themes depending on what decision they make. That hasn't gone away. The government influence, government control, that's still an issue for those who are anti. And when you get mixed messages in Alberta, do what you want. In North Carolina, there's no mandates, I guess. So, there are pockets of people who don't get vaccinated. I think we're going to see over the next couple of years, we're going to see more and more. We've had in Ontario, and I think in Alberta, amongst some groups, measles outbreaks, and I think we're going to see whooping cough again, and we're going to see others where, and now in the States, they changed the guidelines for Hep B, which was supposed to be given in the first 2 months, I think. Now they're saying, well, wait 2 years. There are going to be more cases of Hep B, but that, those are late effects. They're going to happen down the road. We won't see them right away, and they'll blame them on Biden anyway. So it's all about Biden's fault. I'm sorry. I shouldn't get too political. I don't know who's watching, but I, when I see what's going on in the States, with my colleagues who are in this field, some who have lost their positions, some who have lost grants, doing excellent work. There really was a prohibition on, you can't write a grant with the term vaccine hesitancy anymore. That'll be some bureaucrat's going to say, no, we don't. There is no such thing. They've actually said vaccine hesitancy doesn't exist. It's made up. We're living in an alternate universe, a multiverse.
Mm.
I don't know if that answers your question. I got my COVID shot. I got my flu shot. I got my Shingrix shot. I'm going to get my second pneumococcal shot because of my age. I mean, I'm a big believer.
Okay. Another question. Have you looked into Quebec case specifically? Do language barriers potentially affect the rates of vaccination among English-speaking population?
Off the top of my head, no. The one thing we do see is that when you look at the HPV vaccination rates around Quebec, and there was data, I don't know what the recent data is, that the uptake rates of the HPV vaccine outside of Montreal are much higher than in Montreal. And that could be because of ethnic groups, different ethnic groups not having access, maybe not speaking English or French, not having access to the information, not being sure. I'm not quite sure, but that seems to be the case. As I said, Quebec, there seems to be, in general, a sense of trusting the government in general about public health issues and directives.
In your studies, did you find the anti-vaccine movement has a big influence on non-acceptance of the vaccine?
I'm not sure what you mean by the anti-vaccine movement. They're very loud. They're very vociferous. We have an anti-vaccine movement in Canada too. Their governments, like in Alberta, they're not anti-vaccine. They're just changing the mandates. Yeah, the squeaky wheel gets the grease. It's very easy to say something negative. It's a lot harder to prove the positive, right?
Okay. You just want to know if we can get slides. So that's, I guess, another thing.
Well, it's possible, I guess. I could send a PDF. If somebody wants to send me a request by email, I don't know if my email is somewhere, but maybe you could write to Alex,
Mm-hmm.
206 Psychosocial, wherever you got the invitation, and she'll forward it to me.
Yeah.
Okay. Thank you.
Oh, we got one more. Okay. Presently, HPV vaccination of Gardasil was reduced to one dose for the population younger than 18 years old. Should we start to think to increase the age of the admissibility to the vaccination?
When you say increase, you mean upwards? I guess you mean upwards. Well, it is. It's still recommended for still given in schools to pre-adolescents, young adolescents. And it is recommended. A single dose the data seems to show that a single dose, I just saw a study the other day, that up to 5 years has the same levels of immunogenicity as 2 doses. And they're following now these to see if that level of immunogenicity continues longer than that, if you only get one dose. But having one dose, and it seems to be that one dose can be just as efficacious as the 2, which was the standard, that would make a big difference in terms of what's the word? Not divesting, of distributing the vaccine, selling the vaccine to countries that are low and middle income. Yeah. But it's recommended now up to the age of 45, 50 that there seems to be some, and even in women who have had a positive test and maybe have had some kind of an intervention for a lesion, that it's still recommended. It seems to help even after you've been diagnosed with the lesion. So.
What's that? Yeah, and
Okay.
they just want the email of someone. I only have the list of the seminar where no email is mentioned. So that be, I mean, you could be Zeev.
It's zeev.rosberger@mcgill.ca.
Yeah.
Yeah.
That'd be good. Okay. Well, thank you very much, everybody, for your attendance, and Zeev for your
Thanks for
wonderful
having me.
presentation.
It's been a long time.
Lots of good questions, and yeah, thanks everybody. Till next time.